teach fertility awareness to your clients and master the skill of advanced chart interpretation. Learn to support your clients through their cycle irregularities and hormone imbalances with confidence. Our Fertility Awareness Mastery Mentorship is now accepting applications for our next class in January 2026. Head over to fertilityfriday.com/FAMMlive to apply today. That's fertilityfriday.com/FAMMlive. This is the Fertility Friday podcast, episode number 591. IUD insertion pain. If you've been a long-time listener to this podcast, you have heard this topic come up time and time again. Maybe not so much in the recent year, but I previously used to regularly record Pill Reality Series episodes. And in those episodes, I would interview real women, part of the Fertility Friday community, who would share their personal experiences with hormonal birth control and other types of birth control, including the hormonal and non-hormonal IUDs. This phenomenon was something that I didn't really know about so much until I started interviewing women. And when I do the FAMM practitioner series and our practitioners are sharing about their experiences using birth control or other methods, this theme of IUD insertion pain just kept coming up over and over and over again. And while 100% of the women that I've interviewed who have had an IUD placed did not necessarily have an issue with pain, it's really high. I would say it's something like 70 to 80%. And when they describe the pain, it is just excruciating, unbearable, and it varies, of course. Some women continue to have dull aching and discomfort for hours or even days after the procedure is done. And this subject, I don't know if it's as controversial now, but there is some controversy around it because there are many medical practitioners who actually don't believe that women have nerve endings in their cervix. And so they don't even think to offer any type of pain management to them. Well, in today's episode, we are covering a brand new paper. It literally came out in July 2025. And the paper is essentially a consensus statement from the American College of Obstetrics and Gynecologists. Now, this isn't the first statement by them about IUDs, but because it recently came out, I think it's really important that we talk about it and go through this whole situation, I would say debacle. And so obviously this issue is coming up more and more. I think that would be what prompted them to say something about it. But essentially there is this issue with medical professionals not believing that women can feel anything in their cervix, and definitely not taking proactive measures to ensure that women who are having their IUDs placed are comfortable, and even just acknowledging that. So I'm going to talk about what the paper discusses. I'm going to go through that. Now, the paper doesn't only talk about IUD placements. That's going to be our focus today. They do talk about other procedures that involve going in through the cervix and how they should be managed. But I mean, it's just wild to me that this is 2025 and it's like now they're going to do something about this, where women have been suffering and experiencing just these painful experiences of insertion for so long, and it really does, like many things related to women's health, feel like it's falling on deaf ears. So for any practitioners who are listening to this episode, it's also really useful to get a hold of this paper. So you can head over to fertilityfriday.com/591. Of course, we will have the show notes there with the link to the paper so that you can have a look at it. But essentially, this is important information for practitioners and women to know alike, because this also means that ACOG has officially provided some direction and acknowledged this issue. And for anyone, if you're having resistance from a health practitioner around providing some sort of pain management for this procedure, then you can ask for it. And now if you get any pushback, you could literally pull up the abstract or the full paper if it's available and show them, look, the recommendations have changed here. So with that said, let's go ahead and get into it. So I will start with one of the kind of statements that this committee made right off the bat. So according to them, quote, there is an urgent need for healthcare professionals to have a better understanding of pain management options and to not underestimate the pain experienced by patients, and for patients to have more autonomy over pain control options during in-office procedures. Well, duh. I still think it's amazing that we have to have a committee declare this, but we will continue. So they're basically saying in more, you could say, professional language that, so I'll read another couple of quotes here from the paper. They say, quote, the way pain is understood and managed by healthcare professionals is also affected by systemic racism and bias of how pain is experienced. Specific populations such as adolescents and those with chronic pelvic pain, sexual violence or abuse, and other pain conditions may also have increased or decreased tolerance of pain and resistance to pain medications. So, and then they also say something interesting, which is that healthcare professionals should be cautious when extrapolating data on what works for one procedure to another, or even their experience of maybe some patients have been fine with this way and others haven't. So they're kind of, what they're trying to say is, look, we have to actually take this seriously. You have to be aware of the fact that every patient isn't the same. So for example, if you have a medical professional and most of his clients potentially, or most of his patients haven't complained, right? They might be under the impression that there's really no problem. But then how comfortable are your patients speaking up? How many women may be experiencing some discomfort, maybe not enough for them to kind of yell out and say something. And being in the doctor's office is often intimidating, even with a doctor that you've known for your whole life, especially if their kind of default is that this procedure is fine, it just takes a couple minutes. Even if you experience some discomfort, it's not a big deal. Like, how comfortable are your patients even to say anything if you have that disposition? So they actually define pain in the paper, which again is necessary and useful. So they say pain is a highly subjective and personal experience for the individual patient. Again, duh, but they have to actually say that. They have to say that it's not experienced in the same way by everybody. And there's all these factors that could increase how sensitive a person is to pain and what their pain tolerance is. So pain is defined as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. I think this is just indicative of where we're at, where they have to tell the professionals that pain is real and that people experience it differently, because they know that this is an issue that has been going on for some time. And they know that many health professionals don't really believe that women experience pain. And who knows? It could just be that it's easier for them to just go ahead and do the procedure real quick, and actually having to go through a process of assessment and strategizing around pain management options for, quote, a simple procedure might just take too long. I don't even know. I would be really curious to see if there was a paper that looked at the perceptions of medical professionals around pain related to cervical procedures or procedures that involve inserting things into the cervix to access the uterus, or depending on what procedure is being done. I would be so interested. And if I find a paper like that, I'm going to be on here going through it, because I'd be really interested as to like, what is going on in your mind when you are inserting something into a woman's cervix and you just don't think that either it's relevant or a useful use of your time to actually think that maybe this could hurt. If we were inserting things into the penis, obviously there would be like a whole conversation around it, but because it's the cervix, we just are somehow in la la land. Okay, so that's how they open the paper. And I suppose that's my comment on it, where obviously even they are acknowledging that many medical health professionals need education on what pain is and how pain is experienced, and to literally be told that you can't just assume that something isn't painful. You have to actually talk to your patients and find out what their experience is and try to work with them to come to a solution for how to manage it. And I'll just kind of, again, pull out a few more things that I think are really useful. So it says right here, like black and white, pain management may be perceived by healthcare professionals as unnecessary, and in turn, may not be discussed with or offered to patients. Notably, despite patients reporting a higher level of pain than clinicians expect, patients still report a high level of satisfaction with office procedures. So they're also kind of saying, like based on the surveys that they're quoting here, that the patients aren't being offered health professionals. So again, they know what's going on. They know it's happening. And enough women are complaining that this body of medical professionals, this committee, is calling it out. So they know the problem. They know that it's happening. And they also define certain groups of women that may be experiencing more pain or maybe more susceptible to pain. So they identify patients with a history of period pain, specifically women who have never had children. They are kind of calling them out and saying, okay, they may experience more pain. And so from a practical standpoint, if you've never had a child vaginally, then the cervix is tighter, it's smaller. Even from the fertility awareness perspective, there are specific instructions that we share with our practitioners when we teach about cervical position checking. And you can feel, when you feel and palpate the cervix once a day to identify the fertile window, you can feel how open the cervix is. And so before you've had children, the cervix feels like the end of your nose. So if you were to just take a moment right now and touch the end of your nose and just kind of palpate it, typically that is how approximately the cervix feels when you touch it before you've had children. And then during the fertile window, if you were to put your lips together and touch your lips, you can't stick your finger in it, but you can feel a bit of an indent, you could say. And that is how the cervix feels before you've had children. After you've had children, after a baby has gone through the vaginal canal, obviously, then the cervix had to open to allow the baby to come out. The cervix is never again as closed as it will be. So it's always slightly dilated. And so when you touch the cervix after you've had children outside of the fertile window, it will feel firm, but you will feel a bit of an opening. And then once you're in the fertile window, it'll feel a lot softer and the opening will be more pronounced. Popping into today's episode to let you know about our newest resource for women's health professionals, the Practitioner's Guide to Optimizing Egg Quality. This comprehensive guide breaks down the 5 key steps to improving egg quality, along with the top 5 evidence-based supplements to support egg development, mitochondrial health, and implantation potential. Head over to fertilityfriday.com/egg quality to grab your complimentary copy today. That's fertilityfriday.com/egg quality. Now let's go ahead and jump back into today's episode. So from the fertility awareness standpoint, we know that the cervix of a woman who's never had children, there's just very little opening there. There's little give compared to a woman who's had children. But again, they have to identify this specifically. So they also go on to call out specific populations that may have increased or decreased tolerance of pain, resistance to pain medications. So people who just, even pain medications don't really have the same effect. So they're talking about individual differences here. And then, of course, the women who have a history of whether it's pelvic pain or abuse may be more sensitive to pain in those areas. Throughout the study, they also call out certain populations. So they're saying that certain medical health professionals may be less likely to offer women pain medication or pain relief if they are Black or if they are non-white or something like that. So while I don't have a study specifically on that today, we do know that many health practitioners may have certain biases about certain populations and may just assume that they may not even think about it for a certain population where they might think about it for another. And a part of me would wonder if that might be age related as well. It wouldn't be surprising to me if younger women, they just kind of do these procedures and they just don't really think about it. But maybe older women who are closer in age to them, maybe they are more likely to offer because they know who's going to complain about it more, right? Who has more agency to actually say something about it. So lots of things to think about. So what they did essentially to determine their recommendations. So the purpose of this consensus statement is to offer evidence-based recommendations for how to support pain management effectively for a list of different procedures that involve essentially inserting things into the cervix or in through the cervix. And so they looked at a variety of studies over 24 years. So their search period was from the year 2000 to 2024. And they looked at studies that specifically measured interventions. So a variety of different interventions of pain management and how effective that they were. And they have a table. And so they went through, okay, well, what about this? What about that? What were the results of this study when they used this type of pain management? What were the results of the study when they used this other type of pain management? So they looked at it in a methodical, evidence-based, scientific way to determine what is actually working, what is not working, what is more effective, what is less effective, and what is the takeaway? How do we, based on all this data that we have, what are our recommendations? So interestingly, the takeaway from all of this, like so far up to this point, is that they did come to the conclusion that pain is actually real. Women actually do experience pain during these gynecological procedures. They have concluded that it is definitely, like as a fact, underestimated by many health professionals. And there's a problem, there's a need for professionals to kind of come together and sort this out. So, by looking at all the different research and by kind of examining this, they're doing this. Now, I'm glad that this is happening. It is necessary. It's about time. I'm amazed that it's 2025 and this is the consensus statement that's coming out at this point. But at the end of the day, this really validates the concerns that so many women have, that their problems, their concerns, their complaints are falling on deaf ears. So if you've ever felt like a little gaslighted when you're going into a medical office and you're talking about pain, whether it's related to the insertion of something into your cervix or whether it's just related to pain, pelvic pain, period related pain, or, that type of thing, and you're not being taken seriously, this is a real phenomenon, obviously. If so many medical professionals are coming out of medical schools ready to dismiss women's pain like this, then yes, it's good that they came out with this consensus statement. But my hope is that they're actually changing the way that they're teaching physicians and other healthcare providers so that they're not coming out with this bias against listening to their patients and acknowledging their pain. It's really interesting to think about, because then the problem is like how they're taught about pain and pain management, right? If so many of them are consistently dismissing women's pain to the point that they have to come up with a committee statement about it. Okay, so when we look at the results, so they did their assessment, they assessed all these different papers over the course of 24 years, so a really good period of time to look at research around this. So of course, the results show that every woman doesn't experience this the same way. Obviously, every woman does not experience intense pain with insertion. And they say, what it says is that, quote, there are no reliable predictive factors that healthcare professionals can use to gauge an individual's potential for pain. And I think that sentence is interesting because on the one hand, they are saying that there are certain risk factors that predispose a person to have more pain over another potentially. But they're also acknowledging that even somebody that doesn't have any of those risk factors, like someone who has had children or someone who never had a history of sexualized violence or, never had any period pain, it doesn't mean that they're not going to have pain. So they're saying ultimately you can't predict if someone is going to have pain or not, right? Like get that thought out of your head type of thing. And what they also say is every patient who has an IUD placed should receive thorough counseling about the potential for pain associated with this procedure and should be provided with options to mitigate potential pain. So, again, duh, this is something that I've been saying for years. Like, it's just completely unreal. So we're going to link some of the previous period pain or not period pain. We're going to link some of the previous Pill Reality series episodes that specifically are of women sharing their stories with IUD placement so that you can hear for yourself. Like, it's just astounding to me, to the point that anytime anybody tells me that they had an IUD, I would ask them about the pain, because it's just such a huge, like, prevalent problem. And to the point that it's just like, it's unreal how many women have had this painful experience and how common it is, or let me flip the way I'm phrasing that, how rare it is that anyone's offered pain. So of everyone I've talked to over the years, it's very, very few that have ever been offered pain meds. And if anything, the only thing they're told is to take an ibuprofen or something a couple hours before. But as we'll discuss, that was one of the kind of strategies that was not effective, for local, because it's not like a generalized pain that they're having. It's a very local specific pain. So how does taking ibuprofen help you when they stick it in, right? So the specific recommendations for pain management with IUD placement, I did find them to be interesting. And again, it is so helpful when you have data that you can look at, because then you're not just going based on your limited experience. If you're a health professional, you're going based on what actually happens when they look at different methods. Because an individual provider could do only one or two of the 4 or 5 options that they present. And because they're not doing the other options, they might think that what they're doing is fine or something like that. So I think there's a lot of potential for the subjectivity bias when you are just looking at your own experience and not necessarily looking at the data. So they found a couple things that are really useful. One of the things is that what they defined as most effective was the use of local anesthetic agents, specifically lidocaine, for pain management. So they were looking at, and while it can still be uncomfortable, they were saying that, and the way that it was defined, this procedure, is that they would essentially inject a numbing agent into the tissues around the cervix at several points. So when they say to use lidocaine as a local anesthetic agent, they're saying to actually put numbing there, kind of like when you go to the dentist and they put numbing there before they do it. And that blocks the nerve pathways around the cervix, reducing the cervical pain and cramping. And the consensus basically that they came to was based on their research, that was the most effective pharmacologic method for reducing pain during IUD insertion. It only takes a few minutes to administer. Of course, some patients are going to feel some cramping from the injection, and it wears off in about an hour or two. So that's interesting. So we went from, they don't have any nerve endings down there, to actually the research shows that the most effective way to consistently manage this is to numb the area. Again, duh. We will continue though. So one of the things that has also been used for the procedure is what they call cervical ripening agents. So these are agents that then are associated with softening the cervix and potentially opening it a bit. But what the research shows is that the studies that they do using this method, it actually increases the pain and adverse effects. So while this is a common procedure, the research is saying, well, it doesn't really work that well. It actually makes it worse. And they say adverse effects of misoprostol, so that would be the name of the cervical ripening agent that's used most commonly, include abdominal pain, diarrhea, low-grade fever, and increased risk of IUD expulsion. Again, this is why having data is so helpful, because we can actually see, okay, well, this is working better, this is not. What a concept, right? And I'll also share a quote related to NSAID. So getting back to the ibuprofen strategy, which if you're listening and you've had an IUD placed, that was probably, like, if you were told anything about pain management, I feel like you're probably told that. Take some ibuprofen or take some Tylenol or something. So it says, interestingly, available evidence does not support pre-procedural administration of NSAIDs, so ibuprofen, as an effective intervention for reducing pain at time of IUD insertion, despite evidence demonstrating their efficacy in managing pain during endometrial biopsy, a seemingly similar procedure. So they're saying, even though it seems to work with a different procedure, which would be the biopsy, it doesn't seem to be effective with IUD insertion specifically. And so, the researchers kind of clarify that obviously taking an ibuprofen typically is a low risk intervention. So it's not like it's causing harm, but they're saying it doesn't work. It doesn't actually provide relief for the actual moment of insertion. So I'm broken record here because it's like, well, obviously, why would it? It obviously doesn't do anything for the actual moment of insertion. So here we have it. The actual research is saying that if we want to consistently and effectively control pain, we actually need to numb the area. Did you know that you can listen to Real Food for Fertility for free with your 30-day trial of Audible? Head over to fertilityfriday.com/realfood to listen now. That's fertilityfriday.com/realfood. So I have something to say outside of all of this, just as a practical thing, because I've had many women who've had this procedure tell me that doctors would recommend to come when they're during their period, because then the idea is that the cervix is open a little bit, because it has to be open a little bit to let out the bleeding. But again, going back to the fertility awareness perspective, for any woman who's checked her cervix throughout her cycle, when is the time in the cycle when the cervix is softest and most open, even more so than on the period? Obviously, it would be during the fertile window. So, I'm not saying that that's going to get rid of the pain altogether, for sure. But you can feel how hard and firm the cervix is outside of the window. And if you've never had a child before, you can't even feel an opening, right? So if there was a practical time to even with the administration of pain medication, if there was a practical time to go and get the IUD placed, I would think it would be during the fertile window, when you can actually feel how much softer the cervix is, and you can actually feel the indent of the opening. Again, especially for women who've never had children. Now, I'm not saying that if you have had children and the cervix is slightly dilated, that even means that it would be less painful. I don't know. I think that it's possible. And I'm sure that many women would report that. But these are definitely things to think about. Even if you had children, if the cervix is slightly dilated, but you go during the fertile window when you can actually feel that the cervix is softer and the opening is more pronounced. Even isn't it from a practical standpoint easier for the doctor to locate the opening? And one of the questions that I have that I have not seen research about, I would love to, possibly because they're not looking, is, so women are experiencing, some of the stories I've heard, women are experiencing extreme pain, really severe cramping that lasts kind of all day or even a few days after, like really severe pain with insertion. Is there a possibility that that is damaging the cervical cells? This IUD is going right into the cervical canal. And when you have that base of fertility awareness knowledge and anatomy, you understand that the cervical canal, that is where we have our cervical crypts. And our cervical crypts are these delicate cells that produce cervical fluid. And anecdotally, I have seen women who have had IUDs placed and removed, have limited mucus, post removal, at least for a time. And some might have used the hormonal IUD, and that could be related to the hormonal situation there. Some have used a copper IUD. But again, is it possible that if women are experiencing such extreme pain with insertion, that there's some tissue damage? I think it's possible. And to what extent, we have no idea because they haven't studied it. So I'll just briefly mention the other procedures that were looked at in this consensus statement. So they were looking at pain management strategies for endometrial biopsy, hysteroscopy, uterine aspiration, the LEAP procedure, so the procedure that's typically done to remove abnormal cervical cells, as well as cervical biopsy and colposcopy. So they're also looking at what type of pain medication would be appropriate for these different procedures. So for the biopsy, they did also recommend the lidocaine, so the local anesthetic, as well as for hysteroscopy, uterine aspiration, and the LEAP procedure. And only for the biopsy and colposcopy, they said usually the pain is mild to moderate. And so they said the local anesthesia may be used if it's a deeper biopsy or if they're doing multiple biopsies. So generally the consensus was that they should be numbing the area for these procedures. Like if you look at the kind of overall conclusion that they came to, they're saying like, look, the pain isn't good. And so we should actually be doing that. So huge, I don't even know what to say, like huge progress here, or just a wake-up call. So I hope that this is something that's presented at medical conferences to shift the practices of current doctors. But if you're familiar with the research around research, so what I mean by that is if you're familiar with the research on how long it takes research to actually get into medical offices, the estimate is anything from 18 to 20 years plus. So on average, it takes about 20 years for new research to actually trickle into your medical doctor's office. And I would wonder or speculate if the reason is because when you have medical providers that are already out there doing their thing, they may be more resistant to change. And so they may know it all already, right? Like they may know that women don't have nerve endings down there. The procedure's mild, only takes a minute, it's fine. So they may have their preconceived notions about it. So the clinicians that are actually more likely to do the new stuff are the ones that learn it as part of their education when they're in medical school. Now, again, that is just a speculation. And we all know that there's exceptions to the rule. Obviously, there are doctors out there who are aware of this pain issue, who are actively supporting their clients by giving them the local anesthetic and having conversations about pain management, or this ACOG statement wouldn't have happened. So obviously there are medical professionals out there who are aware of this and who are a lot more sympathetic to their patients and what they're actually saying, like who are actually listening to their patients. But what we can gather from the actual experiences of women who've had these procedures, and also this consensus statement, is that many medical professionals are not doing this. And it's probably more likely than not that if you need to have an IUD placed or one of those procedures, that you may not be offered pain medication, or they wouldn't be making the consensus statement and they wouldn't have worded it as strongly as they did. So just to kind of wrap this all up, right? Like, what are the takeaways? What do we do? So ultimately, pain is real and obviously underestimated, like systemically underestimated. So if you yourself need to have a procedure, it is worthwhile to make sure that you advocate for yourself. That's something that needs to happen. And it puts us in a difficult position as women because I feel like advocacy is very difficult. It's one of the hardest things, especially when you're just one person and you're trying to advocate for some change within this huge system. And especially when many providers don't look favorably to their patients actually telling them what to do or even suggesting what they should do, because they're the ones that know best, right? But at the end of the day, that is something that unfortunately you have to be prepared for unless you want to experience a lot of unnecessary pain and struggle. And so in terms of advocacy for pain management, it means you have to be vocal about it. And potentially if you're speaking to a provider who is not open to it or is convinced that it's fine, it's a simple procedure, it only takes a second and then it'll be over, whatever. If that's the pushback that you're getting, then you may need to find another provider. Like honestly, if you ask for pain support for IUD insertion or one of these other procedures that involves the cervix, and your medical practitioner is telling you that you don't need it, I feel like you possibly need to find another. And that's not easy either. It's hard to find doctors. Many people don't have a primary doctor. And that's a whole thing to just keep going from person to person. But it is significant. And these are flags, right? It would be like you go on a first date with someone and they're not willing to like you trip and fall and they're just, and your knee is bleeding or something. And they're just like, yeah, just scrub it out, like brush it off. It can't hurt that much, right? Like, whoa, what is wrong with you? So another takeaway, of course, is that the common strategy of giving somebody ibuprofen or Tylenol or whatever as like a general thing, like, oh, just take 2 Tylenol, before you come. And that doesn't work. So collectively, the consensus was that that is not an effective strategy. What they did conclude is that the local anesthetic, the lidocaine, is what works. So overwhelmingly, that strategy of actually injecting anesthetic to the area was consistently the strategy that was most effective for reducing pain for the IUD insertion, as well as all of these other procedures. So that was basically the recommendation that topped all the other recommendations. The cervical ripening agents do not work and actually make it worse based on the research. So that was one of their conclusions. And based on what they're saying healthcare practitioners, hey, listen to your patients. They're saying that everyone isn't the same. And just because something works for one person doesn't mean it's going to work for another. And you can't tell by looking at somebody or any of their traits if they're going to experience pain or not. So there may be some patients that fall into this kind of more likely to experience pain category, but that in of itself doesn't even tell you if they will or not, because it's a very individualized issue. So the takeaway from all of that is medical providers, stop thinking that you know if someone's going to experience pain or not. Just give them the pain options, right? That is huge. And I would say if you're a women's health practitioner listening, it's important to be able to help your clients to advocate for themselves and to share information like this with them so that they are more empowered. It's often very intimidating to be in front of your medical provider and you're saying something and they disagree with you, right? That puts you in a difficult position because they're the ones with the power. And if you disagree with them, sometimes it can create a very difficult situation. No one likes to be called out, right? But at least if you have, because it's like, oh, what'd you do? Look on Dr. Google. Well, it's like, actually, no, there's an ACOG statement that came out in July 2025, and it specifically states that providers should be providing different pain options for their patients. And what they came to was that the local anesthetic was more effective than the other options. And that was from a study of these interventions over the course of nearly 25 years. They weren't expecting that response, right? So at least if you're in the ring and you have to fight, it's better to fight with data because then it's harder for you to be ignored. So that brings us to the end of today's episode. If you found this information to be compelling and you can think of someone who needs to hear it, then I highly recommend sharing this with your friends, with your colleagues. This is important information. We need to get it out there. It's obviously on my long list of pet peeves of women having to have these negative experiences, these painful experiences, their feelings and remarks and just being ignored. So this is huge. And I was really excited to share this information with you today because I think it's so important. So fertilityfriday.com/591. If you want to share this information, you can always also head over there. And like I said, I'll share some of my previous podcast episodes on this topic specifically, just women sharing their experiences with their IUDs and with their contraceptives. So we'll share some of the past episodes on that. And of course, we'll also link to this consensus statement paper so that you can have a look through it and just see what their findings were. So with that said, I hope that you have a wonderful weekend whenever you're tuning into the show. And of course, as always, until next time, be well and happy charting. If you're loving the podcast and you're ready to apply fertility awareness strategies in your women's health practice, then I know you'll love our Fertility Awareness Mastery Mentorship. It's a 9-month immersive experience that will completely transform the way you work with clients, allowing you to not only teach fertility awareness, but to use the menstrual cycle as a vital sign and diagnostic tool in your women's health practice. Our next class starts in January 2026, so there's still time to reserve your spot. There's no other program like this offered anywhere. Transform your practice in 9 months. Head over to fertilityfriday.com/FAMM live to apply now. That's fertilityfriday.com/FAMM LIVE.